It's supposed to be, this is the first lecture in the GIT course, but I postponed it because يعني تعرفون الوقت احنا يعني الانترنت والدوام والكذا، حبينا نعطيكم الاشياء الاساسيه بالبدايه، وانا هاي على اساس خليكم اخر شيء. لكن اليوم صار ظرف عند استاذ ساجد فانا حبيت اعطيكم هالمحاضره. Oral cavity malignancy is a very important subject, although it is not so common, but it is still, there are a lot of cases really of يعني of CA tongue and CA of the mouth. This is very important. And the most common sites, this is appear in the blue discoloration. The most common sites for oral squamous cell carcinoma in the floor of the mouth and in the retromolar area and behind the tongue. Why؟ من يقدر يتوقع ليش هذه المكانات هي المور كمان سايت؟ من يقدر يتوقع ليش شنو السبب طلاب؟ عيني
الليف نود هنا دكتور قريبة عليها.
شنو يصير؟ شنو؟
دكتور الليف نود هنا قريبة عليها
لا 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 ما له علاقة. لا عاشتي هسه عافية ما دام منتبهين. لا مو هذا السبب. هذا السبب هو most dependent part of the saliva. انت لما يعني you know the saliva about 500 cc to 1.5 liter per day. The most common cause or predisposing factor for oral malignancy are smoking and alcohol. So in the smoking and carcinogens, the carcinogens in the smoking and alcohol, it will precipitate in the saliva in these dependent parts. These dependent parts in the floor of the mouth and the retromolar area behind the tongue also, and definitely on the lateral edge of the tongue. So these are more exposed to carcinogens. That's what we call it field theory. Field theory, it means all the field, all the mucosa in the mouth and tongue, and all the mucosa, especially in the floor of the mouth and behind the tongue and on the lateral edge of the tongue, these mucosa are exposed to these carcinogens. So they may develop more than one primary tumor. Usually, the patient may develop one side of a primary tumor, and this will be metastasized, and we can't deal with it. But in field theory, and this is also important in colorectal tumors and other tumors, urological tumors, there are carcinogens in exposing the whole mucosa to these carcinogens. So either multiple primaries at the same site, this is called synchronous tumor, or after 6 months, that's to say the patient may have CA of the tongue, and we remove partial half of the tongue, partial glossectomy, and we do flap, and that's all. And after more than 6 months, he may develop another primary tumor, not recurrence, but another primary tumor. We call it metachronous tumor. We will explain this in the next slides. So the oral cavity is important to know the relationship between the oral pre-malignancy and the use of alcohol and tobacco. And alcohol and tobacco act as synergistic action. Each one potentiates the effect of the other. The cardinal features of a pre-malignancy and malignant lesions of the oral cavity, we will see it. It is either ulceration or a mass more than 3 weeks, or sore tongue, just sore tongue. Pain in the tongue. This is very important. You should palpate the tongue properly, and the patient may need investigation, especially MRI, and also the investigation and treatment of these patients. So the risk factor for development of cancer in the head and neck are tobacco smoking, alcohol consumption, human papillomavirus. This is very important, human papillomavirus, and Epstein-Barr virus, a Plummer-Vinson syndrome, iron deficiency, very important, and poor nutrition. These are the predisposing factors. So the principal etiological agents, tobacco and alcohol, acting like synergistic action in the development of squamous cell carcinoma. Squamous cell carcinoma in the head and neck, and will be metastasized to the lymph nodes. Also, human papillomavirus, increasing the incidence of these tumors. The anatomical size, as we mentioned, and as it is appear in the first picture, more common in the floor of the mouth, the lateral border of the anterior tongue, buccal sulcus, and the retromolar trigon. And this, as we said, because the dependency and the presentation of saliva with its content of carcinogens for prolonged time, prolonged exposure, so there may be multiple primaries. The conditions associated with malignant transformation, high-risk lesions, erythroplakia. Erythro, it means red. Plakia, it means patch. So the red patch, this is very serious. And also proliferative verrucous leukoplakia. Leuko, it means white. Plakia, it means patch. IA, and it means condition. So condition of white patch. And this is also very important. We should differentiate it from the coated tongue. You know, as we mentioned, the saliva about half liter to 1.5 liter per day. So in dehydrated patients, there will be coated tongue. This should be differentiated from leukoplakia by scratching with tongue depressor. And also chronic hyperplastic candidiasis. These three conditions have high risk lesion of malignant transformation and malignant disease of oral cavity. There are medium risk lesions, what we call it oral submucous fibrosis and syphilitic glossitis. Syphilis previously was very common and affecting a lot of people. And tertiary syphilis, the gamma, may affecting many parts. One of these parts are the tongue. So syphilitic glossitis are pre-malignant. And also there are three low-risk equivocal lesions. So these oral cavity term used to describe any white patch or a plaque that cannot be rubbed off. And this is the important differential diagnosis, how to differentiate it from the coated tongue of dehydrated patient. Dehydrated patients had low saliva secretions and so have coated tongue. But if you rubbed off, it will disappear. But in condition of leukoplakia, this white patch or plaque cannot be rubbed off or characterized clinically or pathologically as another condition. It is a purely a descriptive term with no histological correlation. Leukoplakia varies from, it may be a small, well-circumscribed, homogeneous white patch to an extensive lesion, maybe extensive, involving large surface area of the oral mucosa. And it may be also either smooth or wrinkled, fissured, and vary in white coloration depending on the thickness of the region. So this condition is a pre-malignant condition, maybe the first stage of carcinoma in situ, and may progress to more advanced tumors caused by tobacco smoking, alcohol, and other causes, what we mentioned. This is the leukoplakia. We call it speckled leukoplakia on the lateral border of the tongue. This is the tongue, lateral border. واضحة صورة الطلاب؟
نعم دكتور.
واضحة
نعم
دكتور.
دكتور واضحة.
On the lateral border of the tongue. And this is histologically, we take biopsy, incisional biopsy, and the biopsy confirm carcinoma in situ. Very important to be diagnosed. We have a lot of cases of CA tongue. So speckled leukoplakia, this is a variation of leukoplakia arising on an erythematous base. It has the highest rate of malignant transformation, more than the ordinary leukoplakia. Erythroplakia, as we mentioned, erythro, it means red. A plaque, it means patch. IA, condition. So the condition of red patch. This condition really is more serious than leukoplakia and have higher, so much higher incidence of malignancy than about 17 times more risk than the leukoplakia. And this erythroplakia occurring less frequently than leukoplakia and defined as a lesion of the oral mucosa that present as a bright red velvety plaque that cannot be characterized clinically or pathologically as any other recognized condition. The lesions may be irregular in outline, طلاب إذا هو irregular in outline شو تتوقعون more risk of malignancy or less risk؟
more risk.
عشان more maybe irregular in outline and distinct from adjacent normal mucosa. And the surface may be nodular. Also, if the surface more nodular, this is more risk of malignancy, or broadly atrophic in nature and frequently display contact bleeding. This is characteristic feature of malignancy. Contact bleeding. Just you touch it, there is a bleeding. And this is very serious. And these lesions can coexist with leukoplakia. And the risk of malignancy or in situ changes with erythroplakia is high. Therefore, biopsy is essential, after which surgical ablation is frequently necessary. What are the potential for malignant changes? The potential risk for malignant transformation includes severity and the grade of dysplasia. The more dysplasia, the more risk of malignancy. The more severe condition, the more severe of malignancy. And also increasing the age of the patient. The older patient have higher risk. Also, the increasing the size of the lesion. Size, the more batch, the more increase in size, the more risk of malignancy. Maybe higher in a smoker, although non-smoker may be at higher risk. Not only the smoker really, even the non-smoker may be affected by leukoplakia and erythroplakia. There is also increase in the alcohol consumption and depend on the anatomical side of the premalignant condition, and also particularly high for premalignant lesion on the lateral and ventral surface of the tongue, particularly in young women. We should palpate, you should inspect the tongue very well, and we should, after inspection of the tongue, we should ask the patient to protrude his tongue outside, out of the mouth, and then see the proper condition by inspection. And we do palpate. We do palpate the palpation of the tongue by 2 hands. We wear gloves, and we do palpation of the tongue to see if there is any mass, any nodule inside the tongue, any ulcer in the tongue, especially in the lateral border, and the mobility of the tongue, if it is mobile or restricted by tumor, restricting the movement of the tongue. So what is the field changes and second primary tumor? The diffuse and the chronic exposure of the mucosa of the upper aerodigestive tract to carcinogenic substances like tobacco and alcohol causes widespread adverse changes in the mucosal epithelium. The consequence of the diffuse exposure is the development of separated tumors at different anatomical size. More than one primary. Maybe primary in the right side and another primary in the left side. Maybe primary in the floor of the mouth. These may present similar at the same time. That's to say, we do resection of this tumor and we do reconstructive surgery. Maybe after 2 or 3 years, less or more than 6 months, may present with another primary tumor in the right side. This is not recurrent. This is another primary. We call it metachronous tumor. واضح طلاب السيدكرونس والميتاكرونس؟ لو أعيدها.
صوتك كان
واضح؟
يقطع.
تمام. اوكي. شوفوا هنا this is metachronous
صوتي يقطع ما سمعت.
عيني أعيدها تريد أعيدها؟
يا دكتور عيدها بلا زحمة عليك.
Okay. There are exposure of the oral mucosa to carcinogen. And these carcinogens, like smoking and alcohol, may be dissolved in the saliva. And the saliva in the floor of the mouth, and behind the tongue, this is the dependent part of the saliva positions, saliva size. So these sites are more exposed to carcinogen. There may be development of primary tumor and more than one primary tumor. There may be a focus of a primary tumor in the right side of the floor of the mouth, And another focus of another primary tumor in the left side of the tongue, for example. If these occurs at the same time or within 6 months, we call it synchronous tumor. But if these developed after more than 6 months, we call it metachronous tumor. That's to say, if the patient have a tumor in the right side of the tongue, and we do a resection of this tumor, and we do reconstruction of the tongue, and after more than 6 months, he developed another primary in the left side. We call it metachronous tumor. Is it clear? Or shall I repeat it?
Very clear, actually.
Okay. So this picture is very very nice to show metachronous tumor in the right mandibular alveolus after previous partial glossectomy and forearm reconstruction. So this why this pale patch, this is after the glossectomy. The patient had CA of the tongue. We do partial glossectomy. We remove half of the tongue. We do resection. Sometimes we do partial glossectomy, and sometimes we do total glossectomy. We remove the whole tongue. Okay, but this patient, we did for him partial glossectomy. We remove half of the tongue containing a tumor, and we reconstruct this defect by flap, forearm flap reconstruction, myocutaneous flap, skin and muscle, and we do resection. That's all. And after a while, after more than 6 months, this patient developed another tumor, another primary tumor in the right mandibular alveolus at this time. اوكي طلاب، واضحه هاي الصوره الميتاكرونس تيومر تشرحها لو اعيدها طلاب؟ واضح طلاب لو اعيد؟
دكتور واضحة.
تمام، اشكركم. اي بابا جاوبوا وياي، اشكرك بنتي. So patients who develop a facet tumor in the oral cavity and the oropharynx are more likely to develop a second primary tumor, 15% approximately, and a third of which are in the head and neck. So in total, 80% of these are metachronous tumor, of which 50% develop within the first 2 years of initial presentation. Why? Because still the carcinogens are present. Still the carcinogens are present, which are the carcinogens in the smoking and in the alcohol. So synchronous secondary primary tumor in the head and neck are uncommon, but still they are present. How are the clinical features of oral cancers that warrant investigation? If the patient have oral swelling anywhere in the mouth, in the tongue, in the floor of the mouth, in the buccal cavity, if you have it swelling more than 3 weeks, this swelling need excisional biopsy and histopathological examination. This is number 1. Number 2, if the patient have mouth ulceration for more than 3 weeks, this is also very important and very risky because this ulceration may be due to carcinoma. So it needs investigation and MRI, other investigation, and may need also incisional biopsy. Or if the patient have sore tongue, just pain in the tongue, we should ask the patient to protrude his tongue. We palpate the tongue we wear gloves, by manual, by both hands. We palpate the tongue for any mass, any tenderness, any rigidity, any induration, thickening, abnormal sensation, abnormal feeling. Okay, and this may need biopsy. Or difficulty swallowing because he cannot move the tongue. The tumor of the tongue may infiltrate deeply into the floor of the mouth, causing restriction in the movement of the tongue. So difficulty swallowing. or jaw or facial swelling, and also may present with painless neck lump. Painless neck lump, which is due to lymph node metastasis. So this neck mass, and we will present the size, the most common size, 5 size of lymph node in the neck. Painful cervical lymph node, this is very serious. This may harbor a tumor. The patient may present with a secondary tumor in the lymph nodes. Or unexplained tooth mobility. طلاب بالحقيقة هواي عندنا مرضى مع الأسف خطية يجون unexplained tooth mobility. قد يروح للدينتس، الدينتس يشلع سنه. إذا الدينتس ما ينتبه على الموضوع هو قد يكون أكو underlying malignancy. And sometimes really مع الأسف يعني يكون عندهم bad prognosis. So unexplained tooth mobility is also one of the clinical features of a presentation of cancer of the mouth, oral mucosa, or teresmus. So these are the clinical features of oral cancer that were in investigation. This what we call it oral submucous fibrosis of the right buccal mucosa and soft palate. This clear picture. واضحة يا صورة طلاب؟
واضحة دكتور.
تمام. We will discuss some of the pre-malignant conditions. We start with chronic hyperplastic candidiasis. You know, candidiasis is due to Candida albicans. Chronic hyperplastic candidiasis produces dense plaques of leukoplakia, particularly around the commissures of the mouth. The lesions occasionally extend onto the vermilion and even the facial skin. These lesions have a high incidence of malignant transformation, thought to be a result of invasion of the lesion by Candida albicans. A small percentage of patients have an associated immunological defect. Definitely, this why he developed Candida, this fungal infection. Definitely, the patient is immunocompromised. And this immunocompromised patient will be encouraged of the invasion of Candida albicans, rendering the patient susceptible to malignant transformation. Specific management of chronic hyperplastic candidiasis includes prolonged 6 months topical antifungal treatment. We should use topical antifungal treatment for 6 weeks or systemic antifungal treatment for 2 weeks. If the lesions persist after medical therapy, particularly when dysplasia is evident, on biopsy, surgical excision should be considered. Other pre-malignant condition, what we call it oral submucous fibrosis, which is a progressive disease in which fibrous mass form beneath the oral mucosa. There are scarring, producing contracture, resulting in limited mouth opening and restricted tongue movement. If we ask the patient to protrude his tongue, the tongue is not mobile. Usually the tongue is highly mobile. There are a lot of muscles in the tongue. But in this condition, because of the tumor, there will be restricted tongue movement. And the condition is almost entirely confined to the Asian population and is characterized pathologically by epithelial fibrosis with associated atrophy and hyperplasia of the overlying epithelium. The other condition, we call it proliferative verrucous leukoplakia. This is a rare progressive exophytic variant. Exophytic, it means a tumor mass of leukoplakia, which is frequently multifocal, more than one site, more than one primary site, and carry a high, more than 50% risk of malignant transformation. It is a rare yet distant entity frequently arising in the absence of traditional risk factors for oral pre-malignancy. Diagnosis is made on the basis of combined clinical and histopathological conditions by biopsy. It may be localized and typically affecting the gingiva, or more commonly as a widespread variant affecting the several oral mucosal sites, multifocal, more than one site. And there is controversy as to the best approach to management. However, long-term surveillance is associated with an essential giving the patients permission to undergo any pre-malignant transformation. Yani we should follow up for a long time those patients. Any changes, any disturbances, any abnormal findings, we can take a biopsy. The other pre-malignant condition, we call it sideropenic dysphagia, Vincent or Patterson-Kelly syndrome. There is a well-known relationship between sideropenic, it means to lab iron deficiency in the absence of anemia, and the development of oral cancer. So sideropenia, iron deficiency, which is common in Scandinavian women and lead to epithelial atrophy. Iron deficiency, sideropenia, leading to epithelial atrophy. This epithelial atrophy renders the oral mucosa more vulnerable to irritation from topical carcinogens. So correction of the sideropenia with iron supplements reduce the epithelial atrophy and the risk of malignant transformation. Is it clear the mechanism of sideropenic dysphagia, how to cause malignancy? واضحة طلاب؟
واضحة دكتور.
تمام. So iron deficiency causing epithelial atrophy, and this causing the oral mucosa more vulnerable to irritation from topical carcinogen. In cases of a classification and staging of oral malignancy, we use T and M staging. T for the tumor, mass, size of the tumor, whether it is a mass or ulcer, the size or length of the ulcer. So this is the T for the tumor. And N for the lymph nodes, the cervical lymph nodes and the level of the lymph nodes involving, and the M for distant metastasis. So T and M classification or staging of the patient is very important. T for the tumor, N for the lymph node, and M for the distant metastasis. The pattern of lymph node metastasis, we have cervical lymph nodes divided into 5 principal levels. This is the clear picture. واضحة الصورة طلاب؟ واضحة الصورة؟
واضحة دكتور.
This is the sternocleidomastoid muscle. Sternocleidomastoid. Sterno means sternum. Cleido means the clavicle. Mastoid means the mastoid process in the skull. So the sternocleidomastoid muscle, which divides the neck into anterior triangle and posterior triangle. Very important landmark in the examination of the neck of the patient. And we have the groups of cervical lymph node. Group 1 are submandibular lymph nodes. This is the group 1. This is the first stage of the drainage of the oral mucosa. Group 2 in the upper deep cervical. You know, it is along the course of internal jugular vein. Upper deep cervical. Group 3, mid cervical. Group 3, lower cervical. And group 5, posterior triangle. So cervical lymph nodes, we divide it into 5 levels. A group 1 submandibular. A group 2 upper deep cervical, a group 2 middle mid cervical, and a group 4 lower cervical, group 5 posterior cervical. This picture shows leukoplakia with severe dysplasia. We mentioned if the patient have more severe dysplasia, more risk of malignancy of the lateral border of the tongue. This is the lateral border of the tongue. This is by laser vaporization. We can remove these tumors by laser vaporization. Regarding lip cancer, cancers of the lip of the mouth, lip cancer presented early as it is really visible to the patient. Definitely أول ما يصير عنده شغلة his lip, أكيد he will present it and ask for medical consultation. So it usually arises as an ulcer on the verminal line. In total, 95% of carcinoma of the lips arise on the lower lip, and 15% arise in the central 1/3 and commissures, reflecting the etiological influence of ultraviolet light, sunlight. This is also a predisposing factor. Ultraviolet sunlight radiation on the more exposed lower lip, more than the upper lip. So tumors tend to be spread laterally over the mucosal surface and also may be metastasized by lymphatics to the lymph node metastasis, usually to the submental and submandibular lymph nodes, and occurring in approximately 5% of cases and reflect aggressive disease behavior when apparent. Because it should be presented earlier, but if there is lymph node involvement, this is more advanced disease. This patient have squamous cell carcinoma of the lower limb. Squamous cell carcinoma. Why in the lower limb more كمان؟ هسه ذكرناها طلاب.
دكتور أكثر عرضة اليوفيلات.
عاشت ايدك يا بطل. شو اسمك انت؟ شو اسمك؟
دكتور محمد صادق.
عاشت ايدك يا محمد. بارك الله بك. رحم الله عليك. This is the tongue, this is the mouth, and this is the tongue. This is tumor in the floor of the tongue. Ulcerative squamous cell carcinoma of the anterior floor of the mouth. This is, and the lower picture shows extrophytic squamous cell carcinoma of the right lateral border of the tongue. So you should examine the tongue and the mouth properly and ask the patient to protrude histological examination. So the clinical features of oral cancer that warrant investigation, we mentioned it. If the patient has persistent oral swelling for more than 3 weeks, mouth ulceration more than 3 weeks, sore tongue, difficulty swallowing, jaw or facial swelling, painless neck lump, which means lymph node metastasis, unexplained tooth mobility because there is underlying tumor, and trismus. So what are the investigations? When a clinical diagnosis of oral cancer is suspected, a comprehensive protocol of investigations should be instituted. A tissue diagnosis, biopsy, is very important. Typically by way of incisional biopsy is essential. Formal examination under anesthesia is desirable, particularly for advanced stage disease, not only to carry out the biopsy, but also to palpate and examine the extent of the tumor, which can be tender in the conscious patient. So if the patient, the tumor is tender, painful, because there are perineural metastases. Metastases are surrounding the nerves, and this causing very severe and tender mass. So we cannot examine the patient properly. So when we expose the patient under general anesthesia to take biopsy, also we can examine him properly. Under the same anesthesia, extraction of teeth with a dubious prognosis can be performed. The biopsy should be generous and include the most suspicious area of the region, as well as normal adjacent tissue. And we should avoid area of necrosis or cross-infection because these are not informative. Other investigation, this is biopsy. Before biopsy, we can take radiograph, X-ray. A radiograph of the jaw is undertaken to facilitate adequate dental assessment rather than as a means of assess for evidence of bone invasion. So simple X-ray of the face or the jaw appear if bone invasion if this is an advanced condition, but also to assess the dental condition. MRI, the most important diagnostic tool in the oral malignancy. If you have suspicion of tumor of the tongue or oral mucosa or mouth, floor of the tongue, floor of the mouth or the tongue, MRI is very important. And also PET scan, PET scan, posterior emission tomography combined with CT. This PET scan is also very important. Ultrasound is sometimes beneficial. Fine needle aspiration cytology and radionuclide study to assess bone invasion. Radionuclide study to assess for bone invasion. Now come to treatment of oral malignancy. We have general principles. The management of head and neck cancer necessitates multidisciplinary approach There is no only one doctor or one specialty involved in the management. We should be a team integrating the combined skills and capabilities of surgeons, plus the oncologist, plus the radiologist for radiotherapy, pathologist, and lead health professionals to deliver an optimal treatment strategy seeking to maximize oncological outcomes while mitigating or restoring loss of normal form and function. So we have teamwork, multidisciplinary approach, surgeon, oncologist, radiologist, pathologist, and also for health professional, because definitely the shape of the patient will be changed in cases of CA tongue and mouth, and the flap we did for the patient, and the function speaking, ruling of saliva, so he needs support. Surgery remains the primary treatment modality for oral cavity, where adverse pathological features are apparent based on resective pathology. Post-operative radiotherapy after surgery, after resection of the primary tumor, maybe with the involved lymph nodes, the patient may need radiotherapy or chemotherapy, adjuvant therapy. This is important. Giving the critical normal function and demands of the oral cavity and associated structures. Reconstruction of the ablated surgical defect is frequently necessary to restore or best possible form and function. As I told you, if the patient has CA of the tongue, and we do glossectomy, partial resection, or removal of the tumor, maybe in the floor of the mouth, of the lymph nodes, and reconstruction of the flap, the shape of the patient will be changed. And also the function, he cannot swallow, maybe cannot speak properly. Collection of saliva in his mouth, he cannot swallow his saliva. There may be ruling of saliva from his mouth. So these need reconstructive surgery, supportive management. And options for reconstruction will depend on the defect, site of the defect, and size of the defect, relevant patient comorbidities, the clinical environment, facilities, and importantly, the skill set for of the treating surgeon. So this is leukoplakia. If there is, this is the tongue, leukoplakia with the severe dysplasia of the lateral border of the tongue. This is treated simply by laser vaporization. If it is just superficial mass, without invasion, without lymph node metastasis, we can treat it by laser vaporization. And this is in cases of, say, of the lower lip, skin markings of wedge excision of the lower lip and primary closure. We can do if it is early tumor, if it is early, presented early without lymph node metastasis, we can do wedge resection, V shape, and after طبعا with safe margin of the normal tissue, we remove it with the tumor, because there are microscopical metastasis, not apparent macroscopically by naked eye. So not only remove the primary tumor, but with a safe margin of looks like normal skin and normal tissue. And after this wedge resection, we can do primary suturing if it is early tumor. And this is if the patient have ulcerative squamous cell carcinoma of the tongue, lateral border of the tongue. So an examination, you should examine the patient properly, ask him to protrude his tongue, and palpate by, you wear gloves, sterile gloves, and palpate the tongue, see the lateral border of the tongue, the under surface of the tongue, palpation of the tongue, any sore tongue, any abnormal thickening, abnormal induration, abnormal mass. You should examine the lymph nodes. Lymph nodes should be examined also of the draining part to exclude any malignancy. and any metastasis for a proper assessment of the patient. And if the patient have advanced tumor, as we mentioned, if have advanced tumor, he may need a glossectomy, partial glossectomy. We remove and cut half of the tongue, or maybe total glossectomy, and reconstruct this defect, this major big defect, by flap, by cutaneous flap of skin and muscle from the forearm or other sides of the body, with deltoid يعني flap if there is in the floor, يعني the tumor in the floor of the mouth. Is it clear طلاب المحاضرة? Do you have any question?
دكتور هذا إذا سويناه total restriction of the tongue يعني هذا شو راح ياكل شو راح
هو طبعا هو يريد هنا. ليش احنا نقول تيم وورك؟ هو نريد احنا اما نسوي له فلاب بايوكوتينوس فلاب. طبعا في حاله اذا هو ادفانس تيومر احنا ممكن نسوي له فيدنج جيجينوستومي، نخلي له فيدنج جيجينوستومي اذا هو ادفانس تيومر and cannot swallow، نقدر نسوي له فيدنج جيجينوستومي. The problem this tumor طبعا if it is early مثل ما انت تشوف احنا راح نسوي له باي ليزر vaporization. If it is localized, we can't do localized resection of this tumor with safe margin. But if it is major and a big advanced tumor, because the risk of invasion of major blood vessels causing severe bleeding, so if it is possible, we remove this tumor. If he cannot طبعا an advanced tumor, as we mentioned, he may need jejunostomy, for example, feeding jejunostomy. The problem is with يعني aspiration pneumonia, the collection of saliva really, and if he cannot swallow this saliva, it is maybe aspirated to the chest. So it really الحقيقة it is bad prognosis, and we discussed now the advanced cases. That's why you should diagnose the tumor earlier. You should think about it, and you should advise the patient to stop smoking, stop alcohol consumption, and you should find the tumor earlier. If you find the tumor early, can be treated by just laser vaporization, which is simple, or by injection of needles, radioactive needles inside the tumor. Okay, or we can resect it by just local resection. But if you ignore it with advanced stage, definitely have bad prognosis. That's why it is very important to keep it in mind and to diagnose the patient, MRI, biopsy, and ask him to avoid the risk factors, smoking and alcohol. Okay. اوكي. تحب اشرح بعد اكثر؟ واضح طلاب؟ لو انت اللي سالت، بدون اللي سالت حضرتك؟
انا دكتور.
شو اسمك؟
علي حازم.
حياك الله علي. علي واضح؟ لو تحب اشرح لك بعد اكثر؟
لا هذا دكتور واضح.
تمام علي.
بالنتيجه اذا سوينا توتال ريسكشن يعني باد بروجنوسيس.
هو معناته اوريدي هو ادفانسد، اوريدي اجنورد ادفانسد. لذلك انت تبدي ويا نيل بروفيلاكسيس، افويد سموكينج اند الكحول، تمام، وتريتمنت اوف بابيلوما فيروس، ابشتين-بار فيروس الى اخره، والبريديسبوزيف فاكتورز اللي حكيناها، كرونيك كانديدياسيس وسبميوكوس فايبروسيس والى اخره، تبدي له من البروفيلاكسيس. بعدين النكست ستيب تبدي له انت فور ايرلي دايجنوسيس. should be early diagnosis. If it is a small ulcer, if it is a small mass, before metastasis, it can be treated by laser vaporization, by other maneuvers, or local resection. لكن إذا صار advanced with lymph node metastasis, big tumors, definitely they have bad prognosis. That's why early diagnosis is mandatory by MRI, by biopsy, etc. واضح علي؟ لو تحب أشرح لك بعد أكثر؟
واضح دكتور. عشتك.
عشتك انت، الله يحفظك. شكرا. طلاب عندكم اي سؤال؟ طلاب اكو اي سؤال عندكم عيني؟ لو واضحه المحاضره. المهم اذا عندكم اي سؤال انا حاضر عين.
ممكن سؤال؟
تفضلي بابا تفضلي.
دكتور اللوكوبليكيا اللي تصير ويا اللوكيميا هم تصير على اللاترال side of the tongue يعني، هم نسوي لها investigation يعني.
هو اني ليكوبليكا بنتي يعني اللوكيميا احنا يعني موضوع احنا اني ليكوبليكا مثل اللي هي وات باتش يعني اوكي not disappear by يعني خلينا نقول by rubbing of the tongue depressor. If it is present we should treat it, we should investigate it, we should do biopsy, we should take biopsy of the leukoplakia, and if this is still يعني we should يعني take biopsy or we should treat it. طبعا leukoplakia is serious. Leukoplakia it means يعني pre-malignant condition and have a risk of malignancy, we should treat it. طبعا واضح؟ لو تحبين شنو سؤالك بالضبط يعني واضح؟
اي دكتور واضح.
أني leukoplakia بنتي أني leukoplakia this is يعني serious. أني leukoplakia we should treat it. اوكي؟
اوكي دكتور.